இவங்க கிட்ட சொல்லிட்டீங்களா? இவங்க கிட்ட சொல்லிட்டீங்களா? பிரபா மேடம் கிட்ட
பேசிட்டு இருக்காரு. 2 minutes.
co-host.
2 minutes.
Okay.
ராஜேஷ் பாபு சார், நான் எல்லாரையுமே கோ-ஹோஸ்டா மாத்திட்டேன்.
மாத்திட்டீங்களா?
Open பண்ணிட்டீங்க.
கோ-ஹோஸ்டா போட்டுட்டேன்.
நோ ப்ராப்ளம்.
வீடியோ ஆடியோ ரெண்டு ஆன்ல இருக்கு.
And share screen வந்து நான் multiple participants can share அப்படி கொடுத்துட்டேன். So all anybody can share, sir.
Okay.
So good afternoon, Chiranjeevi sir. Good afternoon, Giri
Good
sir.
afternoon.
Good afternoon, Kanan sir.
Okay.
Sir, good afternoon.
Sir, good afternoon, Edwin Fernandez sir. Good afternoon.
Good afternoon. Good afternoon.
Good afternoon, Giri sir.
Good afternoon, sir. Ramesh Babu sir. Good afternoon.
Good afternoon,
Good
Siranjeevi
afternoon.
sir.
Good afternoon, Giri.
Good afternoon, Siranjeevi sir.
Good afternoon.
Shall we start the program, sir?
Shall we start?
Kannan sir?
Good afternoon.
First of all, I request all of you to please enter your name, your register number, your mail ID, your mobile number in the chat box, so that we will be able to get the credit hours once the formalities are over. So it is better all of you please enter your name, your registration number, your email ID and your WhatsApp number. Please enter in the chat box.
2869. Email ID vcna@yahoo.com. NEPH at
Kannan sir?
yahoo.co.in.
Name, registration, and email ID, sir.
Name, registration number, email ID and WhatsApp number.
WhatsApp number 99.
For speakers and moderators, not to mess there. Already your numbers are there. Kannan sir? Good afternoon, everybody. We will start the program. First of all, we will have the IMA prayer and physician's prayer. The IMA prayer. May everybody be happy. May everybody be healthy. May everybody be free from pain. May everybody be free from sorrow. May we be the healing cure beyond every greed and lure. Physician's prayer. Dear Lord, thou great physician, I kneel before thee. Since every good and perfect gift must come from thee, I pray, give skill to my hands, clear vision to my mind, kindness and sympathy to my heart. Give me singleness of purpose, strength to lift at least a part of the burden of my suffering fellow men and a true realization of the rare privilege that is mine. Take from my heart all guile and worldliness, that with the simple faith of a child, I may rely on thee. Now we will have a welcome address by Professor Dr. R. Kannan, our chairman, IMA AMS, Tamil Nadu chapter.
Good afternoon to everyone. I'm sorry for the poor connection which I'm having. I'm actually for an emergency. I'm traveling to Madurai, and there's a connectivity is not very good. So on this very momentous day where we are celebrating the World Kidney Day, we'd like to thank நட்பு கரங்களை கொடுத்த நட்பு உயர்ந்த மனிதர்களாக விளங்கும் நட்பு இயக்கத்தைச் சேர்ந்த அனைத்து நெப்ராலஜிஸ்டுக்கும் தாழ்மையான வணக்கம். I know it's a very tough time and on a busy day, that is on a Friday. Giri sir, Chiranjeevi sir and Edwin sir have joined us. Thank you so much. And our Academy of Medical Specialties from IMA, our association with NATPU goes 2 years, 3 years before. Even during COVID, we have had a lot of programs with them. And every time we call Chiranjeevi sir, in fact, when Chiranjeevi sir was in United States, also I've disturbed him late in the night. And in spite of that, he has joined us. And Edwin sir and Giri sir, we have known them for a long time. Thank you, sir, for joining us. So I would like to bring greetings from my state president and state secretary. The state president is actually waiting to meet the health secretary. And because of that, he's not able to join us. He said he will finish the meeting and then he will be joining us. And on this important day, where the World Kidney Day, we have two important speakers, that is Giri sir and we have Edwin sir who are joining us. And I would like to take the privilege of using this opportunity to introduce all the speakers and the people. Rajesh sir, I'll introduce them also right away, Rajesh sir. Very much easier. I would like to introduce Professor Siranjeevi sir, who is the professor and head of nephrology from Meenakshi Medical College, and the Institute from Kanchipuram, undergraduation from Tanjore, MD General Medicine from Madurai Medical College, DM Nephro from Madras Medical College. Government service in 1998, started as a tutor, retired as a professor and head in 2008. He is attached to Meenakshi Medical College. Chapter and Indian Society of Nephrology Southern Chapter. Sir has got a lot of first during his tenure in KMC. He established the renal transplantation. He started the DM Nephro course at KMC. He has been the past president of NAPO with special interest in acute renal failure, renal transplantation, and glomerular diseases. And he has got many publications and he has obtained Best Paper Award at ISN Delhi. Thank you, sir, for joining us, and sir will be the chairperson. We also have with us Edwin Fernando sir. Edwin Fernando sir, he is the professor and head of the Department of Nephrology from Government Medical College. At present, he is the president of the NATPU team, and sir has graduated from Madras Medical College, MD from Stanley, DM from MMC again, and he is an ISN fellowship member in nephrology in 1997. Edinburgh, MRCPs. He is an academic advisor for the Government Stanley Medical College. He is an for the transplantation and for the International Society of Nephrology. Award of Excellence continuously he has been winning 4 years from 8 to 21. Interest in renal transplantation and renal disease. 100 publications, chapters and 200 invited talks, and reviewer of many scientific journals. We also have with us Dr. S.P. Giri, who is a senior consultant nephrologist, kidney care from Trichy, and sir is a secretary from the Tamil Nadu and Puducherry Nephrology Association, and he has got best oral presentation, best oral paper, and oral presentation. He has got multiple publications, and sir has done his MBBS from Coimbatore, MD General Manipal, TNB Nephro from MMC. And sir has got more than 40 publications. He has presented in more than 25 to 30 things, and he's a member of various societies associated with Nephrology Association. With this small introduction, we would like to invite the president of NATPU, Edwin sir, to felicitate.
Sir, 1 minute, sir. I will give the secretary's report and then we will proceed.
Oh, okay. So sorry. So sorry. Yeah, Rajesh Babu sir, your own.
Good afternoon, everybody. We, the IMA AMS chapter of Tamil Nadu, are doing the activities routinely, and this is the time for the secretary's report. So we, Professor Kannan, myself and Arul Jyoti has taken over on 12/12/2021, and we are having a period of 2 years. And on 4th February, we conducted a World Cancer Day program by releasing a small video clipping. And on 13th February, we have released an International Epilepsy Day video clipping. These are all the 2 video clippings. And for the World Kidney Day, yesterday we have released one video clipping, which I will be showing after this presentation. And the World Kidney Day, we have got a video clipping, which I will show you at the end of my slide presentation. And the other activities which we are doing are, we are conducting different workshops. One workshop by name Kritikima, which is having 5 sessions, and the second session was conducted on 26/2/2023. And we are going to start a program, a regional anesthesia workshop, IMA, on April 1st. And it has a fee. And then Sonima is a sonogram workshop. We will be starting in May. And Sosima workshop we are conducted already 5th and 12th February and 5th March. And we are going to start a cardiology workshop on April 2nd, 2023, and going to start a LAPIMA workshop on 15 April 2023. The other activities are the Coimbatore IMA branches are done in the last month. The Radio City FM taught by Karthik Annamalai was given. This was well covered in a public for 1 hour program. 8 interesting questions were there. And the SOSIMA workshop, which was conducted on 5th and 12th of February and 5th March. It was an online program which was conducted by Pradeep Kumar. The program was between 3 to 4 p.m. on 3 Sundays. And the World Cancer Day last month we have conducted on 17 to 2022. We had a nice speakers between 3 to 5 p.m. We had a nice lectures and elaborate session. And then the Tirupur IMA has conducted an activity on 17 to 2022 between 2 p.m. to 4 p.m. on a fever management for pediatrics and adults and surgical cases. And this is regarding a criticum workshop which is being conducted on 26 to 2023. Second session was conducted. And Coimbatore IMA branch once again conducted a program on 28 to 2022 about adult counseling. And it was well covered, and around 100 people attended the program. And regarding the IMA, this is a structured program for anesthesiologists. It is a workshop on regional anesthesia, and a cardiology workshop which will be conducted from Rameswaram, Ramanathapuram. And another laparoscopic workshop which is going to be conducted in the Gateway Clinics, Coimbatore. It is a 6-month course, and which will be starting on 15 April. And then today's program. After completion of this video, we will have the session. 1 minute, I will start the video program. This is the video, which video clipping yesterday we have released. Like this, every month we, on the national days or international days, we used to release some video program, and we release it and send it to the doctors and also to the public. Thank you for watching. And now it is time for the sessions to be started. And I request our chairperson, Professor Dr. V. Siranjeevi sir, to take over and have the discussions. Welcome you, sir. Siranjeevi sir.
Rajesh Babu sir.
Yes,
So,
sir.
Before that,
Felicitations.
yeah, before that, can we invite Edwin sir and
Yes, sir. First we will invite Edwin Fernando sir or give the felicitations.
can we request Edwin sir, the president of NATFU, to
Yes, yes. Good afternoon, good evening. It's almost evening now. Good evening to all. And respected Dr. Siranjeevi, Dr. Giri, and all the Dr. Kannan, Dr. Rajesh Babu from the IMA. Thank you for calling us, calling me and having me here as one of the speakers today on to commemorate the World Kidney Day. the second Thursday of every March is commemorated as World Kidney Day. This is commemorated to create awareness about kidney disease and to not only enlighten patients but also enlighten doctors about the need for kidney care and how well to take care of your kidneys. So this year the theme has been a little different, that we have to look at the vulnerable patients and also expect the unexpected. CKD has been seeing an exponential increase in the recent years, partly because of diabetes and diabetic kidney disease. Recently, we have noted that in the rural areas, we see more of undetermined etiology of CKD. We call it CKDU. In a small survey conducted in the rural parts of Tamil Nadu with a cluster population sampling, more than nearly 50% of patients had CKDU, which is actually something new because all along diabetic kidney disease was considered to be the forerunner. Still, we feel in the cities and in the metros, probably diabetic kidney disease would rule. But here's a large group of patients, especially from the rural areas, in whom they work very hard on the field, manual laborers, they don't drink enough water. These are some etiologies that have been proposed to be the cause of CKDU. They present a little differently. They may not have hypertension, they may have polyuria. They don't come to they don't have any symptoms, and so they don't really land up with the practitioner, and they come to us at a very late stage. Since now the dialysis facilities are widely available, thanks to the government and the Chief Minister's insurance scheme, dialysis facilities are there in all the medical colleges. We have 36 medical colleges in our state and also the district headquarters hospital. And the government has also extended the facility to the private nursing homes and hospitals. So we are able to have more dialysis centers. Of course, the key idea is prevention. The other area that we are concerned about is the growing waiting list of patients for transplant. All organ transplants, especially kidney. We have nearly about 6,000 patients in our transplant waiting list. I really do not know when we would finish the 6,000. By the time another 12,000 would have accumulated. We are not able to, the shortage of organs is being addressed, but still we feel that there's a large gap between the patients who have the disease and who require a kidney and who really get a kidney. So this is something of concern. So all this makes us work towards prevention, early detection, and conservative management. As people working in the community, you are the people who are actually seeing these patients first. So we have to educate our young doctors also about the need to recognize CKD, number one. Number two, the early management, how it can be done. We need to liaison with the community and try to pick up these diseases and do our best for these patients. So with these few words, I thank Dr. Giri and the members of the IMA for calling me over here, and I'll be happy to interact with you over the next 1 hour. Thank you very much.
Giri sir, you're on.
Yeah.
Giri,
Thank you. Yeah, thank you, Dr. Kannan, who is the IMA AMS chairman, Secretary Dr. Rajesh Babu, my senior Dr. Chiranjeevi, and good friend Dr. Edwin, and all other members of the IMA AMS. Thank you for this opportunity. We're very happy to be associated with you on this World Kidney Day and to spread the awareness, as Dr. Edwin said, regarding 1, the kidney ailment, 2, early diagnosis, 3, the primary care physician on their role in their management, and last but not the least, to take away the fear of this particular disease. It's not a dreaded one. And last but not the least, dialysis is not a serious disease or a serious procedure that you should be afraid of. If we can pass on this message to all our colleagues and subsequently to our patients, our work is well done. Thank you for the opportunity. Thank you.
We request Chiranjeevi sir.
Okay. Good afternoon to all of you. At the outset, let me welcome all of you to the CME for organized on the eve of the World Kidney Day by the Chairman Dr. Kannan, Chairman of Tamil Nadu State Branch of IMA and his team. The World Kidney Day has been formed in the year 2006 by the International Society of Nephrology and International Federation of Kidney Foundation. The aim is to raise the awareness of the importance of the kidney to overall health and reduce the frequency and impact of kidney disease and its associated health problem worldwide. Every year,
அப்படின்னு எதுக்கு போகணும்னு மனசு சொல்லுது இருந்தாலும் எடுத்துட்டு போலாம் அப்படின்ட்டு போன் எடுக்க போன
Maithili madam, please mute yourself.
Every year a theme is offered during the World Kidney Day. This year World Kidney Day theme is Kidney Health for All, preparing for the unexpected and supporting the vulnerable. The World Kidney Day can be celebrated by organizing marathon walk, run or cycling, or organizing CMEs like what we are doing right now, and as well as organizing medical camp. It is very important to create the awareness, prepare the unexpected, and support the vulnerable people because of the huge burden of CKD and the mortality. As of now, more than 850 million people are suffering from CKD worldwide. Annually, the global death is 1.2 million per year, every year throughout the world. In Indian population, the prevalence of CKD is 17.4% of the population. That means 1 in every 7 people will have CKD. 90% of these people are not aware that they have a CKD with them. India and China alone is harbor about 1/3 of the world load of CKD patients. The incidence is around 800 per million population, combining all the stages of CKD. If you look into the ESRD alone, it is about 150 to 200 patients per million population. This is the commonest cause. This is a 9th common cause of mortality, causing it. More than 18 deaths per lakh of population. In spite of this, only 10% of ESRD populations are getting the right form of treatment, the form of renal replacement therapy or transplantation. So this, with this preview, let me call upon the speakers. The first speaker is Professor Edwin Fernando, the President of the Nephrology Association of Tamil Nadu and Pondicherry, and Professor and Head of the Department of Nephrology, Stanley Medical College. He is an excellent teacher and a brilliant academician who is going to talk to you on epidemiology and screening in CKD. Dr. Edwin, please.
For the unanimous introduction. And, good evening to all the members of the IMA. I shall talk about CKD, the epidemiology, screening, and early diagnosis. I bring to you warm greetings from the Government Stanley Medical College, a hospital that's nearly 200 years old, and a medical college that's about 85 years old. And we function from the 3rd floor of this building, the tower block, and our department functions from the 3rd floor of this building. So this year, the theme is preparing for unexpected and supporting the vulnerable. And we advocate fitness and activity, walking, running, cycling, maintaining ideal body weight, reduction of blood pressure, and reducing the risk of CKD. So this is the theme of this year, preparing for the unexpected and supporting the vulnerable. Now, what is man? When you come to think upon him, but a minutely said ingenious machine for turning with infinite artfulness the red urine of Shiraz into urine. So this was what a famous writer called Denison mentioned about the kidney. So 2016, the theme was kidney disease in children. 17, it is obesity. 18, it was women's health. 19, it's kidney health for everyone, everywhere. And you find that the last 3 years, we've been focusing on the community and trying to create awareness about kidney disease. So what is unexpected? Unexpected is flood, tropical cyclone, earthquake, landslide, tsunami, volcano, heat wave, wildfire. All this has got impact on nephrology in different ways. Unexpected events like the war, in the famine, pandemics like the COVID that we had, power outage, internet outage, interrupted water supply, poverty, unemployment, demise of the caretaker, vulnerable patients with AKI, patients with CKD, patients on dialysis, transplant patients, patients with comorbidities, elderly women, children, and those with disabilities. And we have to prepare steps for the public health emergency preparedness. Most importantly, planning, collaboration, community engagement, risk analysis, early detection and warning, practice, resources, optimal use of social media, learning, and evolution. So we have to address so many issues when we talk about this year's theme. So you look at the epidemiology of CKD in this part of the world. 25% of rural India and 33% of urban India have hypertension. And this is, if you look at the incident prevalence of diabetes, again, if you take the southern part of the country, it's nearly about 12%, but I think numbers are much higher now. So how do you define CKD? Kidney damage of more than 3 months as defined by structural or functional abnormalities of the kidney, with or without decreased GFR, manifest either by pathological abnormalities or markers of kidney damage, including abnormalities of the composition of blood or urine or abnormalities in imaging tests. Or if somebody has a GFR of less than 60 mils per minute for more than 3 months, with or without kidney damage, that is good enough to be called CKD. So this is the CKD heat map. We talk about the different stages of CKD. All this is the nomenclature is uniform throughout the world. So that when we talk about stage 5 of CKD, we all know what we are talking about. So when you refer somebody in CKD4, I understand what you mean, and when I communicate to you, you will understand what I am saying. So please note here, when the proteinuria increases, proteinuria is definitely a risk factor for cardiovascular disease. It's all part of endothelial dysfunction. And after stage 3A, what is marked in red is high risk for mortality because of cardiovascular disease. So CKD is a risk factor for cardiovascular disease. And most often, our patients with CKD die because of cardiovascular disease rather than renal failure itself. We had an Indian CKD registry which looked into about 52,000 odd patients. Diabetic nephropathy was the commonest. CKD of undetermined etiology was about 16%. And most patients came to us at very, very late stages of the illness, that we had no opportunity to do conservative management, but to look at only the to do dialysis and then plan for transplant. And patients with a lower income group of course came later to hospital. Nearly 50% of patients presented only at stage 5. So this is the difference in between the different zones of the country, and you find that, look at the blue bar, almost more than 50% in all parts of the country came to us only with stage 5 of the disease. This is a more recent study that was published in 2016, which looked at about 75,000 odd patients. The prevalence of CKD was about 14% in the general population and 36% in the high-risk population. Awareness about CKD was very low. The general population, 44% had hypertension. 30% did not know that they had diabetes. And CKD burden in India is further supported by this particular study called the Indian CKD study, which showed that diabetic kidney disease nearly was about 15%, and chronic glomerulonephritis, hypertension, interstitial nephritis, all were other common causes. Again, to note that 23% of these patients reported use of alternative drugs after the diagnosis of CKD, which did not lead to any betterment of their condition, but actually led to worsening of their GFRs. Now, if you look at the funding for dialysis in different parts of the world, again, if you look at India, our funding cannot be very high, but thanks to the Chief Minister's Insurance Scheme, the Pradhan Mantri Dialysis Program, and almost every state government has got a program for dialysis. We are able to meet the ends, but then it works out to very huge costs. Now, this is a very alarming slide. If you look at the projection for Asia, the number of patients requiring renal replacement therapy, that's going to exponentially increase by 2030. So this is, again, we belong to this group. Our people belong to this group, and we are going to have tough times considering the number of patients we end up treating. The disease of the kidney can be glomerulonephritis, which is a disease of the glomerulus presence as proteinuria, micro or macro hematuria. Then you have small vessel disease like vasculitis, which could be a multi-system disorder. Times stand up with different consultants. And then tubular injury and interstitial nephritis. This is acute tubular injury, which may progress to chronic, or acute interstitial nephritis that may progress to a chronic interstitial nephritis. Now, the natural history of the disease, it's not often that you find signs and symptoms of kidney disease. Mostly they are non-specific. Same presentation, acute or chronic disease. Most forms of CKD progress to end-stage kidney disease in about 2 to 10 years' time. The interstitial diseases progress much slower. Glomerular disease progresses unusually faster. Among the glomerular disease, the presentation could be oliguria, edema, in early stages hypertension and proteinuria, hematuria. Patient presents relatively early, while somebody with an interstitial disease has polyuria, nocturia, disproportionate anemia, CKD, mineral bone disease, hypertension at a later stage. The proteinuria is generally very low, and these patients present relatively late because symptoms aren't there. Again, I want to underline the importance of urine examination in picking up early proteinuria or hematuria, and that can give you a clue that this patient has a kidney disease. These symptoms, we don't have any rules in medicine. There's no dogmatism in medicine. These are broad categories. However, not all patients would follow all these rules strictly. The urine volume may not change. Some patients may be non-oliguric, but the composition of the urine changes. There is a reduced excretion of the toxic metabolites, may not be apparent until the CKD is advanced. Altered hormone production, anemia, mineral bone disease, and reduced catabolism. So patients on insulin can develop hypoglycemia because as the CKD advances, the insulin clearance becomes poor. The symptoms of this disease, one is of course hypertension, somebody having edema of the feet, and this periorbital puffiness is very classical of kidney disease. And somebody with uremia could land up with any specialist. They could present with seizures and land up in the brain with the neurology department. They could land up with the dermatologist with dry skin, brittle nails, pruritus, decreased fertility. So when they get worked up for infertility, you find that one of the partners has kidney disease. They have a lot of upper GI symptoms: nausea, vomiting, poor appetite, intestinal bleeding, constipation. Anemia may be a very prominent feature. Excess of fluid in the body, leg swelling, facial swelling, high BP, shortness of breath, muscle pain, bone pain, and then heart failure, anxiety, etc. So you find that it is a protein manifestation of this single disease, which actually makes the patient land up with different specialties, and by the time a problem is recognized and they come to us, it's quite late. So we have to screen. What clinical tests would you do? Findings associated with diabetes and hypertension, very important. Heart failure or cirrhosis suggests decreased renal perfusion. Infection with either hepatitis B, C, or HIV may cause proteinuria. Family history is very important. Polycystic kidney disease, medullary cystic kidney disease, Alport syndrome, all this runs in families. Urinary problems, a repeated urinary tract infection may reflect an underlying urinary tract disease. Some systemic diseases like SLE would present with a skin rash, arthritis, mononeuropathy, or systemic symptoms. Recent diarrhea, bleeding, or dehydration may decrease renal perfusion that leads to acute worsening of CKD. A medication history may reveal a drug as an actual cause of CKD. Somebody abusing NSAIDs or somebody abusing some drugs like aminoglycosides, etc., could lead to CKD. In the physical examination, check for orthostatic hypertension, look for rashes, petechiae, examination of the optic fundi for diabetic retinopathy or hypertensive retinopathy, evaluate for heart failure, a renal artery bruit, such as renal artery stenosis, and somebody has joint inflammation, you would think of SLE or somebody with rheumatoid arthritis or an autoimmune process or vasculitis. So our clinical examination is directed towards these. And somebody having encephalopathy or a flapping tremor would suggest uremia. So you'll begin by doing a urine examination. We look at specific gravity, pH, red cells, WBCs, proteinuria, CAS, crystals, serum creatinine, which is the test of kidney function. It is not a foolproof test of kidney function, but this is all that we have right now. Electrolytes, blood counts, liver functions, lipid profile. And if the GFR is less than 60, we look at the calcium, phosphorus, parathyroid hormone, alkaline phosphatase, 25-hydroxyvitamin D, and the renal ultrasound for hydronephrosis, cysts, and stones to assess echogenicity, size, and kidney symmetry. So normally the kidney in an adult is about 9 to 10 centimeters. In diabetics, it may be larger, 11 or even 12 centimeters. If the kidney is small, in an adult, if the kidney size is, let's say, 8 or less than 8, probably you must think that this patient has got CKD. What is more important is to look at the cortical echogenicity, the cortical thickness. Other tests, if indicated, antinuclear antibody, ANCA for vasculitis, and somebody can have a multiple myeloma where we need to do electrophoresis and light chain assay. Serologies for hepatitis B, C, and HIV. And in stage 4 and 5 CKD, we look for hyperkalemia, acidosis, hypocalcemia, hypophosphatemia. And how to classify the CKD by GFR and albuminuria. Determine cause. So we call this the CGA classification. Cause, the glomerular stage, and the albuminuria stage. So the cause could be the presence or absence of systemic disease. Somebody with SLE and kidney disease could be lupus nephritis. Somebody with vasculitis and kidney disease could have ANCA-related vasculitis that could cause the kidney disease. And classify patients of CKD to 3 broad categories: diabetic kidney disease, hypertensive kidney disease, or a non-hypertensive, non-diabetic. So an ounce of prevention is worth a pound of cure. Most of the CKD patients are asymptomatic and are detected during screening, either during routine or for unrelated illness. Going for a cataract surgery and then finding out a creatinine of 3 or 4. Somebody having a pre-employment checkup and finding a creatinine of 3 or 4. Or going to the lab for some unrelated illness and then CKD is being picked up. So don't go by the urine. Where people in CKD can still make urine. The composition of urine changes. Most people do not notice change in the urine volume. With oliguria, people will notice. Patients advanced CKD nearing dialysis may not notice any difference in urine output. So increase in urine volume or night frequency can be a clue to renal disease, and these questions will be very specific, and unless you ask for, may not the patient may not come out with this. So we have to put in a probing questions, leading questions to find this out. So when somebody faces CKD, this is called the Kubler-Ross change curve. Initially, there is a denial, and then they experiment with alternate therapies, and finally come to an acceptance stage. Of course, there's a lot of anger, there's depression. On top of it, economic constraints, social problems, emotionally related issues, all this come into play. So when we tell somebody's got renal failure, first question is, I'm normal, I don't have any problem, my urine output is good. Why do you tell me that I've got kidney disease? So this is the first step that any patient would ask us before coming to reality and accepting what is the problem. Now, this is a very interesting picture. You look at stage 5 CKD on dialysis. You look at the 5-year survival. It's about 46%. The 10-year survival is on 15%. But however, when you transplant this patient, the 5-year survival increases to 75%. That's why in early young patients, we push for transplant, because his quality of life is going to be better, his survival is going to be better. Somebody hooked to a dialysis machine psychologically could be an issue, and patients on dialysis do not tend to do well in the long term. Cardiovascular disease would predominate, and then other complications related to vascular access, mineral bone disease, etc., would prevail. And there is, if you look at the burden, the access, and the disparities in the kidney disease, the current CKD detection programs, if you look at the low middle income countries, it's only about 6%. Lower middle income is about 20%. Even in the high income group, it is only about 32%. So this is what we would like to probably have in determine an individual or a population at level risk, screen for CKD, you confirm CKD, risk stratification, staging, and prognosis, and then treatment. If there is no CKD, then well and good. If it is a vulnerable population or a diabetic, you'll have to screen maybe at periodic intervals. The screening strategy, these are accepted risk factors: hypertension, diabetes, cardiovascular disease. And when we talk about this, we have the microvascular complications. 70% of end-stage kidney disease in the US is attributed to hypertension or diabetes. There is increased risk of retinopathy. 40 to 80% of diabetics have hypertension, and diabetics have 2 times likely to develop hypertension. So the burden of diabetes and hypertension is huge, and most of the causes of CKD are because of hypertension and diabetes and a different comorbid. Somebody with diabetes could have very bad peripheral vascular disease. They have a high incidence of stroke and heart disease. So what are the other age groups that you will screen? Older age, after the age of 40, the GFR starts falling. So older people are definitely at the risk of CKD. Race, ethnicity, certain diseases are more severe in African American race. SLE, HIV, family history of kidney disease, genetic risk factors, low socioeconomic status, because these patients may not take good care of their hypertension and diabetes. Environmental exposures, more and more is being spoken about this. We have an entity called Mesoamerican nephropathy in the Central America, in a country called Nicaragua, where unexplained renal failure has been found in the workers working in the sugarcane fields. So what has been implicated is that most of them are they work for long hours in the sun. They do not have enough water, and they get into multiple episodes of probably an AKI due to volume depletion, and that leads to CKD. There have been some reports of diseases like leptospirosis, which normally cause an AKI, that could progress and produce a CKD. Somebody had a prior history of acute kidney injury is more prone to develop CKD because it's believed that after an AKI, a patient does not completely recover. So there is some residual damage. Preeclampsia predisposes the patient to kidney disease. So a pre-eclamptic lady should be followed up long term. Nephrotoxins, we have plenty of toxins in our country. One is nephrotoxins, of course, prescribed in allopathic medicine where the patient keeps on repeating the prescription. They go to the pharmacy repeatedly and keep buying these drugs. And, you know, in a country like ours, we can have the over-the-counter prescriptions. Anybody could go to a pharmacy and get any drug. And of course, we have our friends from the alternative group of alternative system of medicine who put in a lot of drugs, the nature of which is not known. And most of us agree that many of these are nephrotoxics and contribute to kidney injury, could worsen underlying diabetic kidney disease or hypertensive kidney disease. And of course, we have this endemic of obesity in our country. So obesity definitely predisposes to kidney disease, to glomerular disease, to stones, renal stones, and also to renal cell carcinoma. So obesity is definitely a risk factor for kidney disease. So the initial screening and diagnosis approach would look at a creatinine and a urine albumin to creatinine ratio. Serum cystatin C has been spoken of as a better marker. However, it's not available routinely to the clinician. And looking at the cystatin C, it's expensive, and it may take a while from now before we adopt it as a test. And then we have these different equations for CKD. All of us have Android phones, and I would request you to look at what is known as the MDRD equation, that is modification of diet and renal disease. So when somebody's GFR is less than 60, please use the MDRD equation. And if you're dealing with a normal individual, use the 2021 CKD EPI equation. I need not really go into these details. In your Android phones, you can calculate, you can download these calculators and then just fill the creatinine, the age, and the sex. You will get the value. Almost all labs now give the GFR along with the serum creatinine. So there are multiple formulas. So look at MDRD equation and then the 2021 CKD EPI equation. The Cockcroft-Gault formula that we've been using for long, right from 1976, can be used to calculate the doses of drugs in somebody with low GFR. Looking at the urine, we have to look at the albumin, which is a marker of kidney damage. We have to look at the urine protein creatinine ratio. The ACR, the albumin creatinine ratio, definitely is a standard of care. It quantifies urine albumin, standard for public health, clinical care, and research. Of course, there are a lot of things that you have to roll out before, criteria that you have to roll out before you do an urine albumin creatinine ratio. So the urine albumin creatinine ratio is the most sensitive test to become albumin. The urine protein creatinine ratio comes next. The automated urine strip is next. And the manual strip is the last. So if you look at a screening test, probably you should do the urine albumin creatinine ratio. Urine albumin and eGFR is assessed in type 1 diabetes with a duration of more than 5 years, and all type 2 diabetes regardless of treatment, including the time of diagnosis and then annually. In an established diabetic kidney disease, urinary albumin, that is a spot urine ACR and eGFR, should be monitored at least 1 to 4 times per year, depending on the stage of the disease. The kidney and the retina are very closely connected. When we look at the retina, you see the capillary bed as you will see in the kidney. So diabetic retinopathy is present in virtually all type 1 diabetics. About 50 to 60% of proteinuric type 2 diabetics have retinopathy. Proliferative diabetic retinopathy may be a highly specific indicator for diabetic nephropathy. Absence of diabetic retinopathy predicts non-diabetic kidney disease, but cannot exclude the relation of diabetic nephropathy. And please remember that nearly 40% of patients need not have any retinopathy, can still have nephropathy. But I would urge all of you to have a look at the optic fundi or refer it to the ophthalmologist, because somebody loses vision. That's the most depressing thing to have. At very early stages, it is not picked up, and when there is a vitreal bleed, you lose vision, and that could be catastrophic for the patient. So the other thing is looking at the complication, blood pressure, volume overload, electrolyte abnormalities, treatment of acidosis, anemia, metabolic bone disease, and looking at calcium, phosphorus, PTH, vitamin D, etc. So what's the final word? You screen, and if there is a risk factor, consider screening for CKD, UACR, serum creatinine, and if there is an abnormality, a GFR of less than 60, an ACR of more than 30 milligram per gram, markers of kidney disease. If it is yes, classify, risk stratify, CKD stage, and assign the eGFR category that I mentioned to you in the heat map. Identify and treat specific cause of CKD, and assign the albuminuria category A1, A2, or A3. If any of these are not present, then periodically repeat evaluation is mandated. If somebody is screened for kidney disease today and does not have it, does not mean that he will not develop in the future. So it has to be periodically checked. I want to bring to attention a newly recognized endemic region of CKD in southern part of our, of our state. This is called Thonde Mandalam. This was reported by our friends from Chipman, where there has been an unrecognized endemic area of CKD. This is mainly in the coastal southeastern districts of India, the states of Tamil Nadu and Puducherry, extending to Chidambaram, Viluppuram, parts of Dindivanam, and even Tiruchi. So this is the area of the Thonde Mandalam nephropathy that we are talking about. This is a newly described entity. So people working in these areas probably should be looking at these areas. So the ones with nearly, you look at this figure 44, the red area. This is Viluppuram, parts of Tiruvannamalai, Kadalur, where there is a very high prevalence of CKD of undetermined etiology, which is now known as Thonde Mandalam nephropathy. So these are the CKD hotspots in India. First, it was described in the Uddanam area of Andhra Pradesh. Then we have some spots in Cuttack, somewhere in Maharashtra, and this Thonde Mandalam. So we have a long way to go. We have miles to go before we sleep, and the journey begins with a single step. So I stop here with this beautiful drone picture of Stanley Medical College and its surroundings. You see the busy Chennai port at the background, and all the medical college buildings and the hospital and the winds fly over here. So thank you very much for the patient listening. I shall be happy to answer a few questions.
Thank you, Dr. Edwin. Now it's the time for the questions. If there is any questions or clarification from the audience, you can ask.
But we could have a discussion after Dr. Giri's talk also, sir.
Okay. Okay.
We'll have discussion.
Okay. Let me invite the second speaker, Dr. Giri. He's a senior most nephrologist from Trichy, who is the secretary of the Nephrology Association of Tamil Nadu and Puducherry. He is going to talk to you on role of physician in preparing the CKD. Dr. Giri, please.
Thank you, sir. Thank you, Siranjeevi sir, and my co-speaker, Dr. Edwin, Chairman, IMA, AMS, Dr. Kannan, and others for inviting me. After extensively listening to Dr. Edwin on the diagnosis, various investigatory modality Now I thought we shall come down to the clinic part of it. So my role would be is, we are sitting in a clinic as a physician. As Dr. Edwin said, we are the persons who are going to see them first, the CKD population. We identify them, we make a diagnosis, we discuss with them. So the first step is a valuable, important step, like the last slide which showed, start with the first step. The World Kidney Day 2023, we all saw the theme, Kidney Health for All, preparing for the unexpected and supporting the vulnerable. This slide has been shown by Dr. Edwin as saying the natural disasters as the preparing for the unexpected. So I thought we will slightly modify it as preparing for the unexpected events in our CKD population. So we have a CKD population, they are under a follow-up, and then they go in for a setback. We like to identify why the setback has come and what can we do in the rectification of this setback. That will be the discussion of this particular topic. Our talk will start on this with the prescription of CKD. A CKD patient has comes to us. We know that the creatinine is 2, 2.5 or 3. Now we want to write down a prescription. So when you start this prescription, have a checklist. A checklist should have, first is on a diet. Have you told them about the diet? 2, diabetic drugs. If they are a diabetic, have we prescribed the necessary diabetic drugs? Has it been modified according to the eGFR or the creatinine? What is his blood pressure? Have you included his antihypertensive drugs? Last but not the least, he has also a point set about calcium, phosphorus, alkaline phosphatase evaluation. So have we addressed this metabolic bone disease in them? Uric acid therapy plays a vital role, and reduction of uric acid is known to prevent progression. Have we attended to it? Last but not the least, soda bicarbonate after a eGFR of less than 30. Yes, oral soda bicarbonate can be added. Vitamins, anemia correction, and the other list as and when needed. This will be a rough list that we'll have to go through in a prescription that we give on in our patients with diabetic and a non-diabetic CKD population. Once you have a checklist of them, we know that we have covered most of our queries into them. First one is diet. In diet, we start with a fluid restriction about 1.5 or 2 liters per day. Salt being restricted to 4.5 or 5 grams. That is roughly about 10 to 12 pinches of salt should be taken. Generally, they say, as he had shown in a figure, once that starts as an anxiety, goes for a depression, they always tend to have a nil salt diet, which is not useful, but results in hyponatremia. There is one other salt which is available called as chemical salt, which is potassium chloride and named as Lona salt. Such salt addition in their diet produces hyperkalemia and goes in for a very fatal complication early. The permitted fruits are apple, guava, pineapple, and pomegranate. And definitive no for orange, grapes, and tender coconut water. That's about the diet. When you come to the diabetic drugs, first, recurrent hypoglycemias is very common in a stable diabetic patient, and this is an indicator that renal failure is setting in. So any stable patients, sugars are well under control. Suddenly they say, I have episodes of hypoglycemia in self-monitoring. Call them back, re-look at their renal function. Whenever a patient is on OHA and they developed hypoglycemia, this hypoglycemia lasts for at least 24 to 48 hours. So why should you remember that? When we hospitalize them for therapy, we have to keep them at least for 48 hours because they will have a recurrent hypoglycemia when you try to initiate on them. One small step here is whenever they use OHAs and develop renal failure or hypoglycemia, the OHAs can be released from the receptors by using a drug called injection octreotide. Subcutaneously, 1 dose, repeated every 6 hours, releases the OHA from the receptors, and the rebound hypoglycemia occurring after 24 or 48 hours is thus prevented. In OHAs, what are that are very safe? The commonly used OHAs, once the renal failure sets in and the eGFR comes to around 3, the common drug is glycoside, glipizide, and linagliptin are the 3 drugs generally advised. Last but not the least, strict diabetic control is not mandatory with the onset of chronic kidney disease because they do not help you prevent progression of the chronic kidney disease with very strict diabetic control. The strict diabetic control comes only in the early phase of diabetic control, diabetic diagnosis, but in the later stage, it is not necessary. What is important is nearly 90% of these diabetic patients do not require OHA or insulin. Suppose you take 100 patients who ended up in dialysis, about 85 to 90 of them will be on no drug therapy for their diabetic status. 5 to 10% require either insulin and or OHA for the diabetic control. Which type of insulin is better? We can use the short-acting insulin, we can use long-acting insulins, we can use analogs. All insulins are safe with the remembrance that they need to have a reduction in dosage. Even with insulin, hypoglycemia is common, and hence periodic sugar monitoring in a patient who develops renal disease is very vital. Antihypertensive drugs, that is the next drug we go in. When they commonly start off with an AC and ARB, with the progression of chronic kidney disease, we have to take care that we do not use the AC and ARB, or to take care that in the presence of hyperkalemia, we have to reduce the dose and stop the. So instance of hyperkalemia is a high with the onset of chronic kidney disease in a stable patient with chronic kidney disease, so monitor. Beta blockers is the next drug that is used in the absence of COPD or severe cardiac failure. Cardioselective beta blockers are preferred. The preferred drug is bisoprolol or nebivolol. Why? Because both these drugs are not dialysable. However, metoprolol is dialysable and can produce a rebound hypertension post-dialysis. When you try to shift them onto a beta blocker, then they're going to end up in dialysis. Either a bisoprolol or a nebivolol is the drug of choice. Alpha and the beta blocker, carvedilol, is a good drug, mainly used in the presence of LV dysfunction, commonly seen in diabetics with LV dysfunction or a hypertension, severely uncontrolled, subsequently develop renal failure. They may have a LV dysfunction, and this is a preferred drug. If the blood pressure with these drugs are not getting controlled, we should add them on a calcium channel blocker. Though amlodipine is a safe, simple drug, the instance of fetal edema being very high, we are shifting towards cilindapine. And if the blood pressure is still not controlled with cilindapine, choose nifedipine as a long-acting one. If nifedipine is also not getting your control, the next group of drug is alpha blockers like prazosin, which can be used as a short-acting one or a long-acting one. In uncontrolled hypertension, short-acting preparations are preferred instead of the XL preparation. We have the next one called sympatholytic drug like clonidine, very useful drug, brings down the blood pressure quickly, given thrice a day orally. Watch for rebound hypertension when you skip your dosage. The vasodilator drugs, direct vasodilator is minoxidil. In a rare patient where the blood pressure is still not getting control, or 3 to 4 drugs. If the presence of large edema, if you are given adequate loop diuretics, we can add this drug to bring down the blood pressure. Blood pressure reduction is very vital to great extent in the presence of proteinuria to prevent progression. So we have the multiple choice of drug therapy. The aim at the end of antihypertensive therapy is to bring down the blood pressure to as normal as possible with the patient in a comfortable state. Mineral metabolism drugs are there. Do for the calcium, phosphorus, alkaline phosphatase, uric acid, and parathormone once in 3 months. According to the variations, decide on therapy approximately. What is important is hyperuricemia, common in CKD, diabetic, non-diabetic population. Febuxostat is a preferred drug instead of allopurinol in the presence of falling GFR, primarily because allopurinol produces bone marrow suppression and they can produce hematological complications. So in the presence of renal failure, we remove allopurinol and substitute with febuxostat. Very vital. Anemia correction is another arm here, very important. A targeted hemoglobin is 10 grams per deciliter for the presence of chronic kidney disease. However, raising the hemoglobin above 10, studies have shown they have not benefited. In addition, they produce more complications. So in all routine managements, do a CBC. Simple shortcut method is do an MCV. Look at that. MCV less than 80, it is indicated that it is iron deficiency anemia. MCV more than 100, it is probably megaloblastic. Do a ferritin, total iron binding capacity, transferrin saturation, or a B12 if these tests are available. Otherwise, shortcut method is an MCV, which helps you to determine what else to add in our anemia correction. So the anemia correction, if your MCV is low, is iron therapy, short acting or iron sucrose or on polymaltose, subsequent to which we give them erythropoietin. The plain erythropoietin is available, or you have a long-acting erythropoietin like darbepoetin. Oral acting drug is currently available as desidustat. What is important when you use this erythropoietin drug, we develop severe hypertension. So important to look at whether the patient is having severe hypertension as a complication of the drug. And prior to initiation of erythropoietin, we should have replaced with iron and B12 folic acid therapy prior to the initiation. So now we come to these 2-3 points that we like to highlight from the primary care physician, like what you like you to see. One, if you have a recent worsening of CKD status, once you tell the patient that you have a chronic kidney disease, your urea is rising and creatinine is rising, come back after 2 to 3 months. What they do is they tend to do the test once a month in the local lab. Once they see some change in the local lab, they promptly come to you for a review prior and say, sir, I have done a test outside, this is my result, what to do? So if you have a recent worsening of cardiac status, CKD status, why? Always ask for stoppage of drugs. They should have stopped for some time due to non-availability of drugs or to the natural calamities, etc. A recent intake of non-vegetarian diet, important in the history. Sarah said native drug intake comes to 46% of our population. This is an history of native drug intake. Last but not the least, presence of sepsis. They could have developed a viral fever. They could have developed a urinary tract infection. These are all pointers to say that we're going to have a worsening. Sepsis in CKD population, very important step, primarily because this is an immunocompromised state. And in this state, sepsis occurrence is very, very common. The important thing is fever is very, very minimal. So absence of fever, don't think it is not sepsis, but it is sepsis. They manifest as poor intake, nausea, a feeling of chills while using fan, which is very, very important history, is a pointer towards urinary tract infection. More so when you say, do you have a chills or a fever or a feeling of something? Others feel normal while you have a chills feeling. If it is present, it is a feature for sepsis. Urine output reduction is again a pointer to presence of sepsis. Never hesitate to do complete blood count and procalcitonin for a marker of sepsis identification. Majority of our patients whom we have seen, they come with borderline CBC, WBC count. However, procalcitonins are very high. So this is a one important test which will be pointer for sepsis in our CKD population. Sites of sepsis. Where are the sepsis pointers? One, look for history of cough. Look for history of abdominal pain. Whenever you have a patient with sepsis, always hospitalized. When you hospitalize them, 2 things are useful. One, put in a Foley. In a female patients, commonest thing is meatal stenosis after the age of 50. And in a diabetic population is neurogenic bladder produces UTA. This can be circumvented by one simple thing as Foley's. And if you remove the infected urine, they improve in their renal function. In the male, the similar thing is asymptomatic benign prostatic hypertrophy. Again, one is a Foley's catheter. Remove the infected urine, you will stand to benefit. Repeat a CT abdomen. or a CT or ultrasound abdomen, look for hydronephroureter, which are a pointer for an upper urinary tract infection, correction of which improves your renal function. Nausea and vomiting is another common symptom they will come with. This nausea and vomiting is common as per a history of native drug intake. Whenever they give a native drug intake, it indicates that they have used a high dose of diuretic. They can get up a hyponatremia. Low salt diet, whenever the apprehension, they reduce the salt for a very great levels. 3, it can be a pointer for severe uremia. 4, with a high dose of diuretics and native drugs, they can go in for hypokalemia and constipation. Last but not the least, presence of hiccups indicate very symptomatic hyponatremia, needs admission and evaluation. Excessive tiredness is another history that indicates there are complications. The first pointer is hyponatremia. Next one is hypokalemia. Third one is severe anemia. Fourth is due to any cause. Fifth is a GA bleed. Sepsis. Whenever you have these type of excessive tiredness symptoms, always admit them and evaluate. When in doubt, admit. That is one dictum in our CKD text. So the simple rules, these are one of the last few slides that we are covering. The simple rules of this patient, what we see in a CKD population, please tell them again before they leave. Adhere to the diet prescribed. Whatever diet is advised, please adhere, do not modify. No alcohol, no tobacco. Otherwise, you will end up requiring dialysis very early with worsening. Another important thing is mutton and chicken, high doses is detrimental, worsening renal failure. Drug intake, antihypertensives, other supportive drugs, continue as advised. Do not modify as to your whims. Check your blood pressure, check your sugar levels periodically because they tend to change very frequently. As our previous speaker advised, exercise regularly to your body status. Periodic medical examination in the presence of renal failure is at least once in 3 months. In severe renal failure, once a month. Avoid the native drugs. Do not go for alternate medicines. It will produce problems early. Get ready for eventualities. As shown a good curve, the initial thing is apprehension. The next goes for depression. Next goes for alternative medicine. And the curve lastly goes for acceptance. Tell them you have to prepare for the eventualities, prepare for the acceptance, have a AV fistula early. And last but not least, tell them the dialysis is not a very life-threatening disorder or a procedure that need to be feared upon. With a regular dialysis support, there can be a good quality of life which can be achieved in this population. Thank you, one and all.
Thank you, Dr. Giri, for an excellent discussion. Now that both the topics are open for discussion, is there any questions from the audience?
Sir, Giri sir, stop sharing your screen, sir.
I think I stopped, sir. Now Jayanandan started screen sharing, sir.
Okay.
No queries? Any clarifications?
Sir, regarding this Tondai Mandalam problem, why it is more common in that region, sir? The 4 or 5 packets are there in our country now. So what is the reason for this Tondai Mandalam region problem, sir?
Well, that needs more analysis and more studies. We only identified an area, so that itself took a lot of time and effort from the JIPMA team. So now even the Uddanam nephropathy in the Srikakulam district of Andhra, the problem has been there for more than 10 years now, and still people have not come out with the reasons, because there, families, villages of people were affected with renal failure. People have been talking about something in the water. Some people have demonstrated high content of silica in these areas, etc. So nobody is very clear, while there's another group that claims that these are all genetic disorders, etc. etc. So we are not actually very clear as to what exactly is the offending agent in these endemic CKDs, except that the Mesoamerican nephropathy in Nicaragua is being presumed because of the hot weather. We also see a lot of patients who come back from the Middle East, manual laborers or farmers who go to the Middle East, and they work under very hot conditions there. And then we have seen a sizable number of these patients who land up with the CKD. Probably they had some amount of interstitial disease or something earlier, which was not picked up. Because when you look at this, the pre-employment creatinine, that seems to be fairly normal. Now, another 2 or 3 years, they come with the creatinine of 10 milligrams. So probably these hot weather, volume depletion, dehydration, episodes of AKI, plus some nephrotoxic medications, all this contribute. Regarding condomindalum nephropathy, further research and studies are on to find out what could be the offending agent.
Sir. Question, sir.
Good evening, sir. I am Dr. Venkatesh, sir.
Yes.
I want to ask the question that sir told for EGFR calculation, specifically less than 60 ml, he wanted us to use the MDRD equation. Is there any specific reason, sir? We are following CKD-AP for all, sir.
CKD-AP is for normal people, sir.
Okay, sir.
So for somebody with a GFR of less than 60 in renal failure, the MDRD equation has been validated only in that particular population.
Okay, sir.
So if somebody's creatinine is, let's say, 2.5 or 3, you would use the MDRD equation. Somebody's creatinine is 0.9. A normal creatinine does not mean normal GFR. The GFR could still be low, and creatinine is not a very sensitive test of kidney function. If you ask me, is there any better test? As of now, we don't have. We have to still live with serum creatinine for quite some time.
Okay, sir. So in patients with creatinine, very high creatinine, we have to use that MDRD calculation.
MDRD form. Yes, that's right.
Thank you, sir. And are there any immediate warning signs? Immediately, we have to refer to a nephrologist directly when you are dealing with a patient with a CKD, sir. Like,
one is fluid overload, pulmonary edema. They may complain of cough. Actually, it is actually early pulmonary edema. When they lie flat, the alveoli gets flooded with fluid. So this is one. Other is somebody having altered sensorium, seizures, different levels of altered sensorium.
Encephalopathy.
When you see hyperkalemia, these pericarditis, these are indications that you need to refer immediately.
Yes, sir.
Sir, this is
question, sorry, sir. And another question, one more question, sir. Is there any universal fluid restriction for all patients, sir, or based upon their volume status, we can allow some fluids, sir?
Yes. So this is highly individualized. In somebody with a fluid overload, you will try to restrict fluids and salt. In somebody with an interstitial disease, creatinine is, let's say, 3 milligrams, blood pressure is 110/70. Patient does not have any edema or features of fluid overload. You will not restrict fluids and ask the patient to take normal fluids or quantify the urine and ask them to take adequate fluids. So you can also ask the patient to quantify the urine and then advise on the fluids. So regarding diet, salt and fluid therapy, the advice has to be individualized for each patient. There are some broad categories of advice that you give, but then I think diet is something that has to be individualized. There may be vegetarians, there may be non-vegetarians, there may be heavy non-vegetarians or once a week non-vegetarian. Somebody who's purely vegetarian does not take any protein. So one has to find out what they normally eat and then advise them accordingly.
Thank you, sir. Thank you.
I see a question, if creatinine is low, is there any significance, from Dr. Shobana? If the creatinine is low, it indicates that the muscle mass is very low. Creatinine is a muscle protein. So somebody with, let's say, 40 kilos and having a creatinine of 5 has actually got severe renal failure. Somebody who's got 80 kilos and has got a creatinine of 5, it may not be that severe renal failure. So creatinine is a muscle protein. So if you find somebody's creatinine is 5 and it has come down to 3 in about, let's say, 3 months, either there has been an acute event that has been corrected, or the patient has been malnourished and lost muscle mass, and so the creatinine is falsely low. This is something that you should remember. Number 2, in pregnancy, creatinine is normally 0.4 to 0.7 because the GFR increases 150 times in pregnancy. The creatinine falls to about 0.4 to 0.7. A creatinine of 1 milligram or 1.2 milligram or 1.5 milligram in pregnancy or immediate postpartum period would indicate that there is some amount of acute kidney injury.
Sir, can I ask one question? I am Dr. Jalil.
Yes, sir. Yes, sir.
I'm a neonatologist and pediatrician.
Yes, sir.
First, listen to the both speakers, excellent and very lucid, very informative.
Thank
you.
And greetings to everyone. Sir, I just wanted to ask, you have mentioned, any one of you can answer to this, sir.
Yes.
It is UACR or UPCR, sir, both. Many lab, they protein very specific, very to refer for a nephrologist.
There's a lot of disturbance. I'm not able to hear you well, sir.
This is regarding the UACR and UP.
Yes, sir.
Many lab, they only the protein, they we, unless we ask for the albumin, they don't give it.
Sir, Dr. Babu Vijay Kumar, could you please mute yourself, sir? There's a lot of disturbance from your end. Yes, sir. Sorry, I did not follow your question, sir.
I'm sorry.
You asked about you.
This is only the urine UACR and UPCR.
Yes, sir. See, the urine protein creatinine ratio is not a very sensitive test. It helps you to quantify the urine in somebody who has got overt proteinuria. Let us say somebody's got 2+ protein in the urine. Somebody's got 2+ protein in the urine. Then you quantify the PCR. Now, the PCR is an outpatient quantification of proteinuria. Could the administrators mute everybody? I think there's a lot of disturbance. I'm not able to follow.
Sorry, sir.
So if the protein, if the PCR is 2, it means it's roughly about 2 grams of protein per 24 hours. But to pick up early kidney disease, once there is overt proteinuria happening, kidney damage has already happened. So in order to pick up early kidney disease, you have to ask for urine albumin creatinine ratio. Now, this is a very, very sensitive test. Now, in order to perform this test, you'll have to fulfill some prerequisites, like that they should not have smoked, or the blood pressure should be under good control, the glycemic control should be good, they should not have exercised. And if you do this three times and then you find it is consistently high, then you quantify the more sensitive test to pick up early kidney disease. PCR is to detect patients who have got overt proteinuria to quantify.
One more doubt. Detrimental. In case if there is a fluctuation between the hypo and hyperglycemia, in that case, it has a direct effect or any hyper and hypoglycemia, is it a detrimental in a patient with pre-existing disease?
Lisa, you want to take that question?
No issues. Yeah. In the presence of renal failure, the fluctuations of sugar, if it is very high, they are detrimental. Common thing is, suppose a patient is a stable diabetic CKD, the sugar is around 250. He comes suddenly after excessive eating with the sugars of 550. They'll go in for hypovolemia. In addition to this, they go for hyponatremia. This amount of hyperglycemia ends up in urinary tract infection. So whenever you have a high sugars of more than 500, in the presence of renal failure, needs hospitalization. Worsening renal failure is common. Sepsis is common. Either urinary tract infection upper or emphysematous pyelonephritis or a candida UTI will be very common in this situation. Both hyperglycemia and hypoglycemia are an important factor in worsening of a stable CKD diabetic population.
Thank you, sir.
Somebody has asked one question, Shobana, any diet to, no, first one is Anand. The newly diagnosed case of type 2 diabetes, is it necessary to do a protein creatinine ratio or else urea creatinine is more than enough? No, Dr. Edwin sir has already answered. In a newly diagnosed diabetes patient, we need to do both urea creatinine and a urine test because the onset of diabetes in a type 2 diabetes is not clear. They would have had this problem for 4-5 years. By the time they come to you and have a checkup done, it should have been starting off with proteinuria and the EGFR falling off to less than 60. So do both urea creatinine and a urine. Any diet to aggravate nephrotic syndrome, patient is asymptomatic for 7 years, but there's a leg swelling. Any diet to aggravate nephrotic syndrome. The diet to aggravate nephrotic syndrome, it is not much, except that any diet that produces sepsis. Suppose you are not taking a clean fluid, you have developed a gastroenteritis. Suppose you have developed nausea and vomiting. Such of these patients will develop aggravation of nephrotic syndrome. But per se, diet doesn't aggravate nephrotic syndrome unless they have, in addition to nephrotic syndrome, renal failure, which will get aggravated with high protein, animal protein diet.
Can I have a comment on this, sir? As a pediatrician, this nephrotic babies, most of the relapse are triggered by infection, as you have mentioned. Any trivial viral infection can trigger the relapse, even the multiple relapse. And you know that those who suffer exposure to malaria, they go for a permanent remission also. This is another controversial thought. So I don't think so. The diet can precipitate a remission or a relapse.
There is no more questions. We'll close
Rajesh
this
Babu,
session.
sir, please unmute. Sir, there is a eight drugs you have mentioned, sir. What are all the 8 drugs that produces commonly the problems, sir?
Now, which are the problems, sir? I didn't
No, drugs, sir. 8 drugs, sir.
8
drugs, sir. Drugs can produce the CKD, no, sir.
Drugs producing CKD.
8 drugs, sir. Any specifications of the 8 drugs name you have? That's why I'm asking.
No, the commonest drugs that produce CKD is NSAIDs. Any group of NSAIDs that can produce. That is the first. That's a common thing. Is the first one. Any group of NSAIDs is a common thing that produce CKDs. What else is? I didn't think we mentioned it as 8 drugs. Did you, Edwin?
No, sir.
Any nephrotoxic antibiotic?
Yeah, that depends on how usage you use, no, sir. But it is going to be only a temporary acute kidney injury rather than, his question was specific. 8 drugs that produce CKDs.
CKD.
I thought it was a MBBS or MD examination question, I thought. That's a very way commonly they ask, isn't it, Edwin? 8 causes of.
However, at this point, I would like to point out the injudicious use of proton pump inhibitors, especially on a long-term basis. Proton pump inhibitors are something that are very commonly used in practice and commonly consumed by patients for even angina. So somebody has some heartburn, even if it is an angina, somebody pops pantoprazole or a omeprazole or a rabeprazole. So it's been shown that the long-term use of proton pump inhibitors have been implicated in chronic interstitial nephritis by well-performed studies. So if you're using a PPI, kindly use it for a prescribed time, and please advise the patient not to keep abusing this drug as and when he requires. This is something that I want to tell the family physicians.
Sir,
like
one more
that,
question, sir.
Like that, sir. We were telling about the non-steroidal anti-inflammatory drugs and now the proton pump inhibitors are.
Yes.
Like that, any other drug which commonly they are using, which is coming to your routine practice, sir. That's what. Because we are not knowing more about the failures. So only you people are seeing day to day in and out, sir. That's why we are asking about it.
No
So
issues.
by knowing this, we are now, it is an enlightening fact about proton pump inhibitors, sir. So like that, any other drugs you like to mention?
So any drug has to be used for the right indication, in the right dosage, and for the right duration of time. What we have to advise patients is not to keep abusing these drugs and take these drugs over the counter. Somebody has a cold and goes to the pharmacy and keeps abusing antibiotics. Somebody has a recurrent sinusitis, without addressing the sinusitis, they keep repeatedly taking antibiotics. So this is what we mean by nephrotoxic drugs. Of course, any drug could be nephrotoxic. For example, an aminoglycoside used in the right dosage for a specific indication for a specific period of time is fine. But if this patient is going to take an amikacin or gentamicin as per his wish, or if there's somebody prescribing it without looking into the creatinine or asking him some questions about oliguria, etc., then that may be detrimental. And we always advise patients not to take anything, the nature of which is not very clear. This is very common in patients with established CKD who take, there's a neighbor saying something that you take particular this, your creatinine will come down, etc. The other thing is the gym, the people who go to the gym, youngsters who want to have a six-pack very soon, some creatinine powders are there, some very high protein content powders that help to build the muscle. Anybody going to the gym and working for a six-pack has to really work hard. But when there's somebody who's going in and trying to get a shortcut, we have seen many patients who have taken some powders distributed by these gym people to build their muscle, and we have seen a couple of patients who come with kidney disease. So if your patient is a gymmer, tell him that it has to be done in a very gradual manner, not to take any food supplements, the nature of which is not very clear, or when somebody promises something that you get a six-pack in 6 weeks. We should be careful.
So any association of chicken intake with kidney disease and urinary tract infection? Because we find a lot of cases, they give the history of consumption of chicken once they come for with urinary infections and renal stone. Any associations, sir?
To the best of my knowledge, there's no scientific information on this one. Girisan?
But that is a very common association that we always come across. When a patient is a previous history of stone disease, they'll be totally normal. Whenever they have one travel history of 200, 300 kilometers in a car travel, hot weather, not taking water, finally they go to a function where they have a non-vegetarian diet. They become symptomatic of a stone disease within a week or two. That is very common. I attribute this is to be a hyperuricemia that is producing uricosuriya more. In the absence of water intake, they form stones. And that is only in a stone form. That is, if a person is not having stone disease earlier, this problem will not occur. It occurs only when I say 5 years back, I have a stone disease. So now I come with a stone pain with a previous history of travel, which is very common. So we always advise them, when you are a stone disease, you'll have a recurrence once in every year by 90%. 2 is, if you travel with a non-vegetarian diet and less fluid intake, you will develop a symptomatic stone disease. That's very common. With renal failure and non-vegetarian diet, worsening renal failure, rising urea creatinine is very common with a non-vegetarian diet. Last but not the least, recently we had a case of a high load of biryani followed with a GA bleed. Massive GA bleed with the hemoglobin coming from 12 to about 4 in a basic creatinine of 5. So these are very common indications that we commonly see in our general practice. So it is best we advise them if it is a stone disease, travel, fluid intake, non-vegetarian diet, doesn't mix up well. Take care, more so in summer.
Thank you, sir.
Sir, what is the mechanism of GI bleed in this scenario, sir?
GA bleed is very simple, sir. All our patients with CKD are about 40 to 50% of them will have an acid peptic disease, because this is a primary thing that it prones. The uremia makes it very prone for developing acid peptic. And one of the symptoms that Edwin sir has pointed out in first thing, GA symptoms is a major one with nausea and vomiting. In these type of individuals, any trigger that you trigger on, a viral fever, just a fever, a nausea, severe vomiting, newer intake of drugs, any change of drug, all these things can produce a excessive gastritis. They come with pan gastritis or a erosive gastritis with a bleed. So we do multiple upper GI scopies in anybody who have a bleed. For confirmation, we have seen erosive gastritis as a cause of bleed, even with non-vegetarian diet, with 1 tablet or 2 tablets or 3 tablets of even paracetamol, or just a stress would change the scenario towards a bleed. That's a very common thing. So GA bleed is very common because of uremic milieu with a higher acid peptic disease in them.
So any forceful vomiting, they can also lead to malarial
Yes,
wheeze.
leads to malarial also. That is again there.
Yes, sir. I thought
The reason is in patients with GA, with CKD, they have angiodysplasias of the bowel. They can have angiodysplasias of the colon and what is described as a watermelon stomach. So they are prone to develop bleeding, in addition to what Dr. Giri mentioned.
Over to Ramesh Babu, sir.
Sir,
Excellent.
regarding this organ donation, sir, what is the current waiting list status of the kidney recipient?
I didn't get your question clearly, sir.
Regarding the kidney recipients, sir,
Yes,
failure patients,
yes.
what is the requirement in our state, sir? Any ideas?
You want to register somebody for an organ, receiving an
Yes,
organ.
sir.
Is that what you are asking, sir?
That is one. Another one is what is the necessity now? How many people are waiting list? Any statistics you know of now?
Yeah, the waiting list for kidney at present is about 6,000, 6,000 odd.
In Tamil Nadu, sir?
In Tamil Nadu, it is about 6,000 odd. Then whom do you register for a disease donor transplant? The nephrologist has to decide depending on many other conditions, comorbids, etc. So we rule out significant cardiovascular disease or peripheral vascular disease. He should not have significant bladder dysfunction. So not everybody who has got CKD and does not have a live related donor, everybody cannot be put on the disease donor program. Let's say somebody is 75 or 80 years old. We wouldn't put them on a disease donor program because their longevity is going to be much shorter. So it depends on the nephrologist to decide which of his patient is going to go on a disease donor waiting list.
Sir, Professor Siranjeevi, sir?
Yes,
Sir,
there
you
is
can
no
give
more,
you
there
can
is
give your
no more
remarks, sir.
questions from the audience. We are coming to the end of the session. We'd like to thank Dr. Kannan and his team for organizing an excellent CME on the eve of the World Kidney Day. We thank Dr. Edwin Fernando and Dr. Giri for giving a very good lectures so that many people have been benefited by the many physicians are benefited by their talk. Okay. So with this, can I close it, sir?
Sir, vote of thanks by our Joint Secretary Arun Jyoti.
Yes.
Sir, if possible, you please make him as a co-host, sir, Arun Jyoti.
Sir, Chiranjeevi, sir.
Yes.
Can you please make me co-host, sir?
Arul, you can speak like that, Arul. You don't need to be a co-host, Arul.
No, I want
Yes,
to show
sir.
the certificate.
You want to put a
Certificate, sir.
Oh, okay. Sorry.
On the participants, brother.
Hello.
Okay, sir. Shall I speak directly, sir?
Yes, you continue.
Continue. Hello.
Am I audible, sir?
Yes, audible.
Audible.
Yes, sir. On behalf of IMA, AMS, TNSB, I thank all the participants as well as speakers for being online and involved in this World Kidney Day CME hosted by us. Especially, I thank Dr. Edwin Fernando, sir, and Dr. Giri, sir, who is the secretary, and Dr. Sanjeevi, sir, who is the past president of NATPU. And sir, regarding display of certificate, I want to become a host, sir.
Okay.
1 minute, sir. Sir, is my certificate visible?
Yes. Visible.
Yes, sir. Now I like to present the certificate of appreciation to Dr. V. Chiranjeevi, sir, for his role as a moderator and even chairman of the U of World Kidney Day CME, sir.
Okay.
Now I present the certificate of appreciation to Dr. Edwin Fernando, sir, for his lecture on epidemiology and screening in CKD population on this eve of World Kidney Day CME program. This is to Edwin Fernando, sir. Thank you, sir. Next, we like to give the certificate of appreciation to Dr. P. Giri, sir, for his lecture on physician's role in preparing for the unexpected in CKD patients on this World Kidney Day event. Thank you, sir. Thank you.
Can you send the certificates by WhatsApp?
Yes, sir. Sure, sir. We will
send it in mail also. Sir.
Okay.
Yes, sir. Thank you, sir. Thank you very much, sir. And
you,
I request all the participants to please type your name, TNMC number, mobile number, email address in the chat box in within another 10 minutes, so that we will be able to apply for Tamil Nadu Medical Council points for you. Yes, sir.
Thank you, one and all, sir.
Thank you, sir.
Thank you, one and all.
Thank you, all of you.
Thank you, one and all.
Thank you, sir.
Thank you, sir. Thank you very much.
Okay.
Rajesh Babu, sir.
Yes, sir.
Yes, sir. I will document the chat details as much as possible from my end, sir.
இல்ல அந்த ரெக்கார்டிங் வாங்கிட்டு you send it, it will be automatically put up.
Yes, sir. Fine, sir. Fine, sir.
ரெக்கார்டிங் வாங்கிட்டு அங்க அனுப்பிட போதும். நாளைக்கு இவரு
பண்ணிக்கலாம்.